A patient arrives at the clinic with a classic presentation. They describe a sharp, electric pain originating in their neck and shoulder, radiating down their arm along a specific, defined dermatome. Suspecting cervical radiculopathy, the referring physician follows standard protocol. They order an electromyography, or EMG test, to objectively confirm the diagnosis. But the results arrive, and the physician faces a frustrating clinical paradox. Despite a textbook presentation of severe localized nerve pain, the EMG trace returns completely flat and normal. This negative result does not mean the pain is psychosomatic, nor does it mean the lab machinery is calibrated incorrectly. The issue is a persistent clinical misunderstanding of what electrodiagnostic testing can actually measure when a patient presents exclusively with sensory symptoms. This 2022 study by Erkan and Kuruoglu directly addresses this diagnostic gap. They retrospectively evaluated 180 patients referred to an EMG laboratory for suspected cervical radiculopathy, specifically to test how the equipment performs on patients experiencing pure sensory pain. To find out, the researchers stratified the 180 patients into 3 distinct groups. Group 1 reported nonspecific neck and arm pain. Group 2 reported highly specific textbook dermatomal pain. Group 3 presented with objective neurological deficits. During their physical examinations, patients in Groups 1 and 2 exhibited absolutely zero motor weakness and no loss of deep tendon reflexes. Their symptoms were entirely subjective. Group 3 served as the control arm of the study. Every patient in this cohort presented with verifiable objective upper extremity neurological deficits, such as a weakened bicep or a diminished reflex. By drawing these strict boundaries, the researchers could isolate the variables. They wanted to determine if purely subjective sensory symptoms carry any statistical weight when predicting an abnormal electrodiagnostic trace. Isolating pure sensory manifestations from objective motor deficits created a perfect stress test for the actual diagnostic limits of the EMG laboratory. This chart visualizes the diagnostic outcomes for each cohort, and the data for Group 2 immediately stands out. These 25 patients arrived with highly specific textbook dermatomal radicular pain, yet their EMG confirmation rate for cervical radiculopathy was exactly 0. Having a highly specific, localized pain pattern did not meaningfully improve the diagnostic yield over vague, nonspecific pain. Both sensory groups flatlined during testing. The data reveals that the presence of objective motor deficits acts as a binary switch. It dictates whether an EMG referral will yield useful data or simply waste time and resources. A structural cervical defect can cause intense, highly localized pain, but if the patient's motor function remains intact, the electrodiagnostic trace will look perfectly normal. To understand why the machinery is blind to the source of the patient's pain, we have to look at the spinal neuroanatomy. A spinal nerve divides into 2 distinct roots as it connects to the spinal cord. The ventral root carries motor signals out to the muscles, and the dorsal root carries sensory signals back in. Sitting on the sensory root is a cluster of nerve cell bodies called the dorsal root ganglion. When a structural defect, like a herniated disc, compresses the sensory root, it often does so proximal to the ganglion. This creates a preganglionic lesion. This physical compression is what actively generates the patient's severe subjective pain and paresthesia. Now, consider what happens when a clinician runs a standard sensory nerve conduction study. They send an electrical impulse along the arm toward the spine to measure the health of the nerve. Because the dorsal root ganglion sits between the distal arm and the site of compression, the ganglion continues to nourish and sustain the distal sensory axon. The nerve pathway being measured remains completely intact and healthy. This anatomical layout creates a sensory trap. The lesion is real and the pain is real, but because the damage sits entirely behind the ganglion, routine sensory nerve conduction studies will always read as normal. If the sensory nerve conduction study is blind to the lesion, why does the needle EMG portion of the test also fail in these pain-only patients? Needle EMG operates on a strict physiological boundary. It is designed to detect active denervation occurring within muscle tissue. If the ventral root escapes compression at the spine, the motor axon remains fully intact. A needle inserted into the connected muscle will register a flat, normal electrical trace. For the needle EMG to detect a problem, the structural defect must actively compress the ventral motor root. This motor impingement triggers Wallerian degeneration. The nerve fiber physically breaks down, traveling distally down the motor axon, causing the muscle fibers to lose their nerve supply. Without their nerve supply, the muscle fibers become electrically unstable. This resulting electrical chaos produces fibrillation potentials and positive sharp waves, which rhinally spike on the EMG monitor to confirm the diagnosis. The Erkin and Kuru-Oglu study highlighted a critical nuance here. In 43% of confirmed cervical radiculopathy cases, the diagnosis was made based purely on abnormalities found in the paraspinal muscles of the neck, proving that comprehensive screening of the myotome is required when motor damage is suspected. Without motor root impingement triggering Wallerian degeneration in the muscle, the EMG needle has absolutely nothing to measure. It is a tool requiring structural nerve damage, rendering it functionally useless for pure sensory radiculopathy. If EMG testing cannot confirm cervical radiculopathy in pain-only patients, a clinical dilemma emerges. Should referring physicians abandon the test entirely for this demographic? The answer lies in a critical secondary finding buried in the data of the nonspecific pain group. A remarkable 14% of patients with nonspecific pain had unsuspected peripheral issues. These were nerve problems completely unrelated to their cervical spine. The laboratory was able to uncover common alternative diagnoses that mimic radiating neck pain, such as carpal tunnel syndrome or ulnar neuropathy at the elbow. When a patient presents with ambiguous, purely sensory symptoms, the clinical value of the EMG shifts. The goal is no longer to confirm a spinal root issue, but to rule out and uncover hidden distal nerve entrapments. This physiological and statistical evidence provides a clear, actionable triage protocol for referring physicians. Here is a decision tree that respects the actual limits of electrodiagnostic testing. If the physical exam reveals pure pain or paresthesia and localized radiculopathy is the only clinical question, do not order an EMG to confirm it. The test will be negative. However, if those sensory symptoms are ambiguous or atypical, an EMG should be ordered specifically to check for peripheral entrapment neuropathy. Finally, if the physical exam reveals objective muscle weakness or reflex loss, an EMG should be ordered immediately to precisely localize and confirm the structural damage. The objective neurological physical examination, not the subjective intensity of the patient's pain, is the ultimate filter for testing efficacy. By understanding the anatomical blind spots of EMG testing, physicians can stop deploying it as a flawed validation tool for radicular pain. Instead, they can reserve the laboratory for the precise structural localization and alternative diagnoses it was engineered to provide.